welcome to everybody, and thank you for attending this GVN Forefront Virology COVID-19 webinar. It's always a pleasure to welcome new speakers, and as usual, I mean, for those of you who might not be very well aware of what the Global Virus Network is about, just a few words of introduction. So this is really a large network now. We have about 68 research centers worldwide and 12 affiliate centers. It's an independent network, that's a key word. It's science-driven, another key word. Our research are really based, our activities are really based on combining research, education and training, in particular with the GVN Academy, and advocacy communication. And regarding research, we have a number of activities, including task force. And actually, the webinars that we are presenting really contribute to coordinating, I would say, research efforts among the experts of the Global Virus Network. So in this context, it is today my great pleasure to welcome Dr. Rubeshan Perumal. He has a very interesting CV. He is a senior scientist at the Center for the AIDS Program of Research in South Africa for the CAPRISA organization. He is also a specialist physician and pulmonologist at the University of KwaZulu-Natal in South Africa. His activities have been very much focused on HIV, on tuberculosis, but also now on COVID-19. And I just want to emphasize that this is a very interesting case where you can see how some mechanisms can help nurture, develop the career track of brilliant young investigators. And Dr. Perumal has been a recipient of many awards. I'm not going to list all of them, but in particular, Fogarty International Center Fellowship, which allowed him to go to Vanderbilt University and Columbia University. And he has been supported by several programs for skill development by AstraZeneca, by the Infectious Disease Institute, Makerere University, and by the European School of Management and Technology. So this is a case of somebody who has both the medical, the scientific skills, also some management training, and whose career has been supported by different programs which has allowed him to become a senior scientist. And the reason why I emphasize this is that this is also very consistent with what we are doing at the GVN with the GVN Academy program and the Rising Star program to nurture the career of a young and brilliant investigator. So Dr. Perumal today is going to speak about long COVID, the tsunami after the waves. I like the title. And this is obviously a major issue, and the GVN is considering having a task force on this specific issue. So Dr. Perumal, thank you for being with us, and we look forward to your lecture.
Thank you very much for that incredibly flattering introduction. And I think you're quite right that I've been the beneficiary of an incredible amount of mentorship and support over the years. And so it gives me great pleasure to be able to join this network as a member and to contribute to some of its important goals. I'm just confirming that the full slide appears on your screen.
Absolutely.
Wonderful. So thank you again for introducing me and for inviting me to talk about this important subject, which is of inescapable scientific, clinical, and public health importance. I think it is becoming increasingly apparent that COVID-19 is going to throw us many more challenges than those we've seen already. And one of those is in the increasing burden of long COVID. So like many others, I've spent the past 2 years at the bedside of patients in intensive care units. And so I have accumulated a fair amount of clinical experience managing acute cases of COVID-19. And I think it's becoming increasingly apparent that many of us have had to pivot somewhat to taking care of the survivors of acute COVID-19 and are somewhat disheartened to find that their recoveries are not as firm and sure as we thought they would be once we recovered them from such severe illness. In addition to that, the huge magnitude of patients who had, say, moderate or mild disease who didn't come into our care in hospitals remained slightly outside of our reach. And unfortunately, they too have become affected by long COVID and sadly remain outside of our reach. And so today I want to talk about long COVID in its full breadth. And so we'll take a tour of the epidemiology, basic science, some aspects of clinical practice, and public health implications of this new and emerging entity. In order to do so, I will touch on the existing knowledge on the epidemiology of long COVID, some aspects of the evolving definition, looking at trajectories of recovery from acute COVID-19, risk factors which are now established, and several new risk factors which are being discovered for the development of long COVID, and the rapidly emerging science around potential mechanisms for pathobiology of long COVID, where I think the most interesting science is emerging. And then we'll return to a public health focus to talk about what we're going to do about this problem at the clinical coalface. So this disease has caused devastating illness in patients, and I'm talking about acute COVID-19. It's ravaged families, overwhelmed communities, threatened the stability of our healthcare systems around the world. There are now over 400 million documented cases going hand in hand with about 6 million deaths, probably grossly underestimated. And South Africa has not been spared. We've accumulated just over 3.6 million cases, and our recorded deaths are just over 100,000 now. And we're probably closer to the 300,000 mark when we account for the excess deaths. And our epidemic has been characterized by unrelenting waves of disease, and certainly for the first 3 waves, death. And we're increasingly beginning to understand that in addition to disease and death, we now have to face disability amongst patients who simply do not enjoy a full recovery from their acute illness. Now, most of us have spent the past 18 months, at least those of us in clinical practice, at the bedside of patients like the one depicted in the top right corner, turned face down in submission to a deadly pneumonia, their lives dependent on the bellows of a mighty ventilator and a stacking tower of infusions. Really a merciless disease from which we were incredibly proud to recover patients. However, it wasn't too long before we started to see our first patients return for follow-up, completely debilitated, completely unable to return to any meaningful life. And that was the beginning of my journey with long COVID, establishing one of the first, and for a large part of the first 12 months with our battle against this disease, the only long COVID service in the country. While most of our attention was focused on containment efforts and addressing the surge of cases with severe disease, our clinical response must shift to include a new focus, a new emphasis on post-acute care and long-term follow-up of COVID-19 survivors. Now, cases of incomplete recovery and the incapacitating persistence of symptoms have dominated the news headlines the world over. Patients are calling out for help from every corner of the globe, and we are slowly gaining sight of the tsunami following swiftly behind the waves. Global and local recovery rates are quite satisfactory. 90% of people with acute COVID-19 are reported to have resolution of their acute illness. And in South Africa, more than 95% of our patients are reported to enjoy a recovery from their acute illness. But the emerging data on long COVID is less reassuring. About 30% of patients, when surveyed at about 3 months from their initial illness, report that they just aren't quite the same as before COVID-19. And sometimes it is easy for them to point out why it is that they feel that way, and sometimes less so. I hope to share with you some data which will help to characterize these patients, both phenotypically and endotypically, so that we can improve our understanding of what exactly is plaguing this population. But if we translate this figure of 30% of non-recovery from acute illness, we're left with an appreciable number of people who are desperate for care. Globally, it translates to somewhere between 40 and 120 million people who are going to be seeking care if they're not already doing so for long COVID. And in South Africa, it's likely that we already have 1 million or more people looking for our help. Until October 2021, there was very little consensus about whether or not the entity existed at all, and even more so when we did believe it existed, how to define it. But in October 2021, the WHO convened a committee constituted by experts around the world to reach some sort of consensus on a definition for the condition. And it remains a live definition, which is probably going to be revised again in 2022, but largely is made up of 3 important characteristics. One is that the patient should have had a documented or suspected infection with COVID-19, with SARS-CoV-2. There should be at least a lapse of time in the magnitude of about 3 months between the time of their acute illness and the time that you are considering a diagnosis of long COVID. And lastly, they should have some symptoms which cannot be accounted for by another organic process. Now, I continue to use the word long COVID, but the definition is for an entity called the post-COVID condition. Long COVID remains arguably the most widely used descriptor for the condition, and so I'll continue to use it throughout this talk. We are beginning to understand the scale of the problem, and in this study and several others subsequent to it, evaluating the clinical status of patients 3 or more months from their initial diagnosis, there are now more than 50 clinical sequelae documented as part of the long COVID syndromic presentation. And more than half of the patients within these cohorts describe at least or report at least one symptom. The most common of these symptoms are dyspnea, fatigue, and cognitive difficulties. And you can see that even in this cohort, about 1/3 reporting fatigue, about 16% reporting dyspnea, and about 16% reporting cognitive difficulties. The second fact, which is quite clear, is that there's a gradient of risk based on the severity of the acute illness. So, mild patients with mild illness, some risk, those who are hospitalized, greater risk, and those who go to ICU, an even greater risk. This complex Venn diagram on the right-hand side of your screen demonstrates the complexity of the condition. And so if we take this group of 5 patients, they are trapped within 3 different colored bubbles. The first in pink, the second in yellow, and the third in blue. And so they have restrictions in many domains. In this case, they have fibrotic lesions in the lung, they have psychiatric symptoms, and they have cognitive deficits. And you can see how when patients have this kind of complex arrangement of symptoms, it is difficult for them to, one, give representation of those symptoms in a way that is appreciable to a clinician, but also difficult for services to organize themselves in a way that can respond to the condition. So in this, probably the largest and longest series of data on long COVID, reporting outcomes in 1 year from patients with acute COVID-19 in China, the numbers are even more concerning. Here at 6 months, 68% of their cohort remained with at least one symptom. And reassuringly somewhat, I suppose, that reduces to about 50% of the cohort at 12 months. But I'm not so sure about how reassuring that should be. A year later, from a viral infection, half of all patients remain unrecovered or remain with a symptom sufficient enough to bring them to care. You can see that those symptoms reflect those which we spoke about earlier: fatigue, cognitive difficulties, and sleep difficulties certainly emerging more and more strongly in the data, and dyspnea. But one of the things which is perhaps concerning and mainly reflected in this cohort and several others with longer follow-up is that while most symptoms abate over time, there are also those symptoms which seem to increase in proportion and in reporting over time. And here you see that the reporting of dyspnea, pain and discomfort and anxiety and depression increase from the 6-month evaluation time point to the 12-month time point. And so we're likely dealing with a condition which is dynamic, which has an underlying biological mechanism which persists and which, if not interrupted, tends to get worse over time, at least in some aspects. Well, we've talked about the importance of symptoms, but what about the impact on functioning of the individual and on their quality of life? Well, this study published in eClinical Medicine, which looked to fully characterize patients in an international cohort, demonstrated restriction in multiple domains. So if you follow the green bars, you see that the bars are reflecting the inability to perform a certain task. And these tasks are work. I'm going to point out the most important ones: work, the ability to communicate thoughts, to interact with others, to take care of children, and to perform some very basic personal tasks like feeding oneself. And you can see that about 80 to 90% of people are unable to return to work with long COVID. That over 50% cannot communicate their ideas, can't make complex decisions, are unable to engage with their peers and socialize. And just under half find it difficult to take care of their families. And a not insignificant amount of people, between 10 and 20% of patients with long COVID, find it difficult to care for themselves. Now, this is an entity which is having significant impact on individual, social, and occupational functioning. And more than 60% of people find that, almost all of these patients describing an inability to return to some form of meaningful social or occupational function report a considerable change from their pre-COVID baseline. And that was measured in the study. And it turned out that patients with long COVID were about 60% of their pre-COVID function. And so that's a significant amount of loss of function. And perhaps with some implication for the economic activity and participation of these individuals, more than 20% of people with long COVID never return to their work again. Well, what about the long-term outcomes of these patients? And this study was one of the first to signal a very worrying finding, which is that long COVID wasn't just about symptoms which persisted. And this study, which was conducted using an NHLS cohort in England, looked at patients' recovery from acute COVID-19 and compared them to matched controls in the general population, and found that not only did their symptoms persist, but their risk for new major medical diagnoses were increased significantly. These patients had a 6-fold greater risk of a new respiratory diagnosis, a 3 times greater risk for a major adverse cardiovascular event, a 3 times greater risk for chronic liver disease, 2-fold greater risk for chronic kidney disease, and a 1.5-fold increase in diabetes. So the physiological embarrassment from acute illness is truly unrelenting. Now, very recently as a week or two ago, this paper was published in Nature Medicine. And if we weren't convinced by the prior paper in the BMJ, I think this paper seals the deal. It looked at patients who were using Veterans Health Administration facilities between the period of March 2019 and January 2021, and compared patients who had acute COVID-19 to matched controls in a contemporary control cohort, as well as a historical control cohort. The finding was startling. These patients, over the course of nearly 12 months, demonstrated a significantly higher risk for major adverse cardiovascular events and any cardiovascular outcome. And in fact, this risk was present and was significant irrespective of the severity of the acute episode of COVID-19. But in patients who had the most severe form of acute COVID-19, those who went to ICU, their risk was 5-fold that of the general population. And so you can see that acute COVID-19 isn't limited to physiological embarrassments or deficits apparent during the acute illness. In fact, there's a 5-fold greater risk of experiencing a new major cardiovascular outcome in the subsequent months. To take that a step further, this publication in PLOS Medicine looked to identify a risk for mortality over and above the risk for outcomes in organ systems. And it used the Open Safety platform, which is a platform on which 40% of the UK population has some representation, used linked data from the NHS and the Office for National Statistics between the period February 2020 to December 2020. And they compared patients who were recovering from COVID-19 to the general population and matched controls with who are hospitalized for influenza. And they found a 5.79 times greater risk for all-cause mortality at any point in the subsequent months in comparison to the general population. Now, that is a significantly greater risk for all-cause mortality in a cohort of patients who one would assume is recovering from acute COVID-19. And I don't imagine that 18 months from where we are now, that 18 months prior, we would have guessed that patients who recover from COVID-19 would face 5-fold greater risk in death from any cause. And I think this is some of the data which is pointing us in the direction of seeking a greater scientific understanding of what exactly is going on and where is this risk coming from? Why would it be that patients recovered from an acute viral illness should have a 5-fold greater risk over subsequent months for death? Well, we are beginning to identify at least some risk factors for long COVID. And epidemiologically, it's clear that older patients, women, those with comorbidities, particularly hypertension, and individuals of increased BMI are at increased risk for long COVID. In addition, there are now several initial symptom clusters which have a greater risk for progressing to long COVID. And though that's clear from a number of studies, but one cluster emerges quite strongly in its ability to predict long COVID. And that cluster is one characterized by severe fatigue, chest pain, confusion or mental clouding, a loss of appetite or meal skipping, and the early onset of shortness of breath, irrespective of the presence of pneumonia. And as I've shown you, severity of illness too is a predictor of long COVID. And depending on which cluster of symptoms you're looking for, a variable number of risk factors cluster to portend such a risk. Now, Tim Spector and his colleagues looked at predicting long COVID based on initial presentation. And they did this through requesting individuals with new diagnoses of acute COVID-19 to report their symptoms and then subsequently their recovery using a mobile application. Using that data, they fitted a model which looked at a whole host of variables, but ultimately needed only 3 variables to predict long COVID with greater than 70% accuracy. And those variables were age, sex, and number of symptoms during the acute illness. And you can see here that the presence of 5 or more symptoms was associated with an almost 4 times greater risk of developing long COVID. Taking the clinical characterization a step further, and now using multi-omic technology and techniques to build a predictive anticipatory model, this research group looked at combining omic data with clinical characteristics and serology to identify predictors of long COVID. And there are factors which are present during acute infection and others which are present during convalescence, which seem to portend this risk for long COVID. During acute infection, pre-existing diabetes, SARS-CoV-2 viremia, both tend to portend a greater risk for long COVID. Now, 2 factors which are now emerging quite strongly are EBV and CMV viremia. And the data suggests that disabled interferon signaling during acute COVID-19 infection results in reactivation of EBV and CMV. And viremia from these 2 viruses results in a whole host of clinical consequences, some of which may be responsible even primarily for what we see in the clinical characterization of long COVID. And the very last of these factors is the presence of autoantibodies very early in the disease course. And these are antibodies to interferon alpha. And so you can see already a major restriction on viral clearance through the inhibition of interferon alpha by antibody targeting, and then a whole host of other antibodies which we are familiar with clinically associated with common tissue groups across the entire tissue spectrum in the human body. At convalescence, low levels of SARS-CoV-2 antibodies, the emergence of cytotoxic CD8 and CD4 populations, repressed levels of cortisol, and elevated levels of circadian-related proteins are similarly related to long COVID presentations. But the kinetic aspects are really crucial. It is really the dynamic changes within some of these analytes that are crucial. The way in which the antibody levels change from baseline through to convalescence, the way in which viral loads of EBV, CMV, and SARS-CoV-2 change over the course of initial infection into convalescence, which are important. And so this data is being developed further to try and answer some of those kinetic questions. Looking for an immunological signature to predict SARS-CoV-2, this study published in Nature Immunology identified a persistent inflammatory response signature which could detect long COVID with greater than 80% accuracy. And it was comprised of a signature for interferon beta, PTX3, interferon gamma, and interleukin 6. And so interferon lambda and interleukin 6. So this is a signature which was able to predict long COVID with a greater than 80% accuracy. And it is very useful in a clinical scenario where you're meeting a patient 3 months down the line from their acute infection and are looking to ascribe their persisting symptoms to long COVID rather than, say, some other organic disease process. Now, what is not known from this data is whether or not this signature would apply during acute infection. And unfortunately, they didn't collect the data from acute infection. And so the data is being looked at and being reviewed in light of new cohort data to establish whether or not this holds true for signals present during acute infection. Certainly for patients with established symptoms at 3 months, this signature can distinguish long COVID from unexposed healthy controls, individuals with prior human coronavirus infections, and matched controls without long COVID. And this study looks to put together all of these different approaches: clinical characteristics, serology, and in some ways interaction between the elements. And they were able to construct a post-acute COVID sequelae score, which combined IgM, IgG3, an interaction term between those two antibodies, a history of asthma, the number of symptoms at initial infection, and the patient's age, to produce a score which, when used at a predictive threshold above 0.7, is able to predict with great accuracy the likelihood of long COVID. And this signature could be applied fairly early in the disease course. It could help us to identify at-risk patients who should be brought into care early and who should be subject to intense scrutiny and perhaps linkage to research programs. Well, we can't get any further without understanding a little more about the mechanisms underpinning the development of long COVID. And I've constructed this, this picture to try and give an understanding of how complex it is to understand the disease process. At the outer limits are complications related to acute COVID-19, the post-ICU syndrome, and hospital-related complications, which are very difficult to remove from the picture of long COVID, and certainly confound the picture of individuals who had severe acute illness. But once they're removed, there is the remaining symptoms which cannot be explained really by the acute infection. And for those, there are now emerging biological explanations. The first is that of autoimmunity. And we see that there are an increased prevalence of autoantibodies to a wide variety of human targets, importantly to type 1 interferon, and then others to well-described antibodies such as the auto-anti-nuclear factor, anti-RNP, Rho, La, and Jo1, which are reminiscent of lupus type autoreactivity. So these are breaks to self-tolerance to a variety of autoantigens. And we know that this kind of antibody production is not simply hypergammaglobulinemia, which is seen commonly with many infectious pathogens, but really a distinct targeting of particular antigens. And this is because the prevalence of autoantibodies are grossly out of proportion with total IgG. And so we're beginning to understand that autoimmunity might be playing a big role in long COVID. And for that reason, there are now studies of steroids, immunomodulation, and immunosuppression for long COVID. The second emerging idea is that of viral persistence. And this idea is really emerging quite strongly based on data which confirms the persistence of virus, viral RNA, and viral proteins in a whole host of tissues in the body long beyond the period of acute infection. And viral persistence can cause long COVID in several ways. The first is through direct injury, such as infection and damage to olfactory neuroepithelium with persistent anosmia. The second is through indirect injury, where the virus or its nucleic acids or its proteins are resident in tissues in the body, such as the gastrointestinal tract, where it attracts an immunological response, and in doing so creates regional inflammation and thereby produces symptoms in that organ or tissue. Lastly, it's important to remember that SARS-CoV-2 antigens are actually super antigens, at least those which are being identified in these tissues, such as S1 protein. And by that, what we mean is that they toggle the immune system through non-specific receptors. They induce a exuberant immune response, which is not specific enough to effect viral clearance. And they create a loop with ongoing inflammation, ineffective viral clearance, and increasing failure to make the immune response more and more specific for the antigen. And that loop results in chronic inflammation. Now, the arguments for viral persistence beg the question of whether there might be viral reservoirs for SARS-CoV-2. And this study, which looked at biopsies of the small bowel 4 to 6 months after acute infection, demonstrated the presence of SARS-CoV-2 nucleic acids in the epithelium of the small bowel. And more recently, S1 protein has been found in monocytes up to 15 months from acute infection, even in individuals who were reporting improvement in their symptoms. And for that reason, antiviral therapy and vaccination are being looked at for the treatment of long COVID. If that data isn't convincing, then this recently published study, well, not yet published, but in preprint, I'm fairly certain in the near future we'll see it in print, looked at post-mortem data for 44 individuals who died from or with COVID-19 up to 230 days from their diagnosis of COVID-19. And they identified SARS-CoV-2 RNA in a widespread range of human tissue up to 230 days from their acute infection. They went a step further and identified subgenomic RNA, which is highly suggestive of a recent replication rather than, say, the presence of residual RNA from the initial event. And they demonstrated its presence, quite far down the line, as I said, but in tissues far flung from the sites of initial infection. So here's the lung, and we predictably expect it to be there, even if it were there for a long time. But in the kidney, the adrenal gland, the pancreas, in urogenital tissue, and widespread in the brain. And this participant, 42, who was sampled at 230 days from acute illness, demonstrates subgenomic RNA in the lung, in the heart, and throughout the brain. And so this is really giving us the kind of evidence we need to advance the biological hypothesis of viral persistence. Microvascular thrombosis is an idea which I think is emerging quite strongly, an area that is advanced by a South African researcher, Rizia Pretorius at Stellenbosch University, who went on to demonstrate that not only was acute COVID-19 a disease characterized by coagulopathy, but long COVID too seems to be associated with a persistently elevated D-dimer and the presence of persistent analogous amyloid microclots. Now, these microclots are unique for two reasons. The first is that they seem to be resistant to enzymatic degradation. And the second is that they seem to be protected by alpha-2 antitrypsin, which the clot itself harbors. And so the clot is intrinsically resistant to the natural fibrinolytic agents within the human body. And for that reason, there's now high intensity anticoagulation, antiplatelet therapy, and even apheresis being advanced as potential therapeutic options. And these micrographs coming from the same study demonstrate quite nicely the absence of microclots in controls, the aggregation of platelets in acute COVID-19, and then the increased aggregation of these microclots in long COVID. This is just higher amplification. So this is the blood of an individual before COVID-19. It was stored blood from a healthy volunteer. It is a picture of platelet poor plasma, and you can see the paucity of clots. That's the micrographs of the same individual after they developed COVID-19, and several months later, showing the persistence and emergence and persistence of microclots. One step further is the failure for those clots to be enzymatically degraded by trypsin. So, this is an idea which could explain why there is microcirculatory arrest, metabolic failure at the tissue level, and a whole host of multi-system affectation, which could be explained by something diffuse like microcirculatory arrest. A persistent brainstem dysfunction is another potential biological mechanism, and it stems from the understanding that SARS-CoV-2 exhibits tropism for the brainstem. And there are ACE2 receptors and many other co-receptors present throughout the brainstem. Interestingly enough, the brainstem is enriched for numerous nuclei, which give expression clinically to a whole host of symptoms when affected. And you can see that these nuclei in the brainstem correspond quite neatly to the protein, but often now well-characterized clinical manifestations of long COVID. The hypothesis is that there are probably more than one hit resulting in brainstem affectation, and there's probably direct infection, neuroinflammation, microthrombosis, and most recently postulated is microglial hyperactivation. And this has been shown through both autopsy data and now PET imaging. And for that reason, there is ongoing interest in steroid and neurochemical manipulation for long COVID. Mast cell activation syndrome is an emerging explanation for long COVID, and really its biological plausibility arises from the fact that mast cells are widely known to be activated by SARS-CoV-2, and persistent aberrant activation beyond acute infection can result in the enumeration of a whole host of transmitters and mediators, chief among them interleukin-6 and histamine, which can produce a whole host of symptoms, including fatigue, neurocognition, nasal congestion, neurocognition deficits, sleep disturbance, and tachycardia. And there's emerging data, at least from epidemiological cohorts of MCAS patients, which show that treated MCAS cohorts developed less severe COVID-19 and a lower prevalence of long COVID, and untreated MCAS cohorts developed a greater amount of severe COVID-19 and a greater prevalence of long COVID. And so there's some interest in advancing this idea. For this reason, antihistamines, mast cell stabilizers, and a low histamine diet alongside SSRIs are being looked at as potential interventions. Now, the postural orthotachyc tachycardic syndrome is a syndrome characterized by autonomic dysfunction, and its biological plausibility arises from the finding of autoantibodies to alpha and beta adrenergic receptors in patients with long COVID. The result of these antibodies is that there's increased sympathetic responsiveness, so that when people move from the lying position to the standing position, there is a sympathetic surge, which results in a tachycardic response, which is inappropriate. And these patients often mount a rising heart rate of greater than 30 beats per minute on standing to heart rates above 140 beats per minute, with a whole host of accompanying symptoms at that time. And for that reason, there are now studies of volume expansion, compressive stockings, fludrocortisone, ivabradine, and beta blockade for the treatment of long COVID, which is characterized by this exaggerated heart rate response. Now you can see that there are rapidly emerging mechanisms for long COVID, some of which have more evidence and others still emerging, but they are probably interlinked. And this web of interactions, which I constructed based on the papers themselves, exploring each of these mechanisms, shows that there's a clear and probably emerging nexus that we can't see clearly right now, but must exist between all of these various interacting mechanisms. Well, the question then must be, what about vaccination? Can vaccination save us from this increasing burden of long COVID? Well, there's a clear answer for the question of whether vaccination protects populations from long COVID based on the mere fact that a lower number of people will come to be infected with long COVID, provided we don't see a large amount of immune evasion, certainly not the extent that we saw with Omicron. But vaccination would need to protect from infection in order to have a substantial effect on long COVID at that level. But what about breakthrough infections? Can vaccination reduce your risk of developing long COVID after breakthrough infection? Now, this data from the NHS and from the ONS demonstrates that individuals who developed breakthrough infection were 50% less likely than unvaccinated individuals who developed COVID-19 during this time period to develop long COVID. So vaccination seems to protect against long COVID, even when breakthrough infection occurs. And that's an important protection, given that in the UK, at the time of the study, there were already 1.27 million people with long COVID, representing 2% of the UK population. And now these studies add to that evidence, because this paper published in Lancet demonstrated a 49% lower risk of long COVID in patients who had received 2 doses of a vaccine for COVID-19. Now, that was a protection which was afforded to both younger individuals and the older individuals who were at greater risk for developing both severe COVID-19, acute COVID-19, and long COVID. And similarly, this study shows the sort of same effect where twice vaccinated individuals seem to be well protected against long COVID, a 50% reduction in most symptoms across the board. But sadly, both studies confirm that a single dose of vaccine doesn't do the trick. No different risk for long COVID as unvaccinated individuals. So that's important from a public health perspective. Well, what about vaccines for people who have already developed long COVID? Well, this study, which is currently in preprint, demonstrates that about 50%, almost 60% of individuals who are vaccinated after having developed long COVID report an improvement in their long COVID following vaccination. And so I think that's promising for individuals who go on to develop long COVID in an unvaccinated state. Well, what about variants and long COVID? Is Omicron likely to cause as much long COVID as previous variants? I think the answer should be fairly generic. There doesn't seem to be a biologically plausible reason to expect variants to cause different risks for long COVID. So certainly based on the biological mechanisms which we currently understand to be at play. But there are 3 factors which will determine the likelihood of long COVID for each variant. We know that if a variant causes less severe disease, then it will generate a lower proportion of patients with severe disease and hopefully a lower proportion of patients with long COVID. However, if the variant is more transmissible, then it will create a large number of people with mild and or asymptomatic disease who we know are not spared from a risk of long COVID. And while they're at lower risk than those with severe disease, numerically, they may constitute a very large number of people. And so we might end up with a higher overall burden of long COVID. And then largely, it might depend on how immune evasive a variant is, because this might have implications for the degree of viral persistence and long COVID, if we are to believe the biological mechanism of viral persistence as a leading mechanism for long COVID. Well, what should we do at the public health level? Well, we should start establishing services to bring patients who are recovering from COVID-19 into care so that we can survey them for non-resolution, and we can link them to research programs so that we can understand their disease process better and offer them linkages to therapeutic interventions as soon as they arise. At the minimum, these individuals should have good control of their comorbidities, a broad clinical evaluation, an evaluation for major organ dysfunction arising from their acute injuries with acute COVID-19, and that might be as simple as a lung function, chest radiograph, and ECG. They should have some access to symptom control, good general health interventions, and linkage to rehabilitation services. And so basically what that means is that discharge planning is essential, that follow-up care must become entrenched in our care of COVID-19. We should be able to link patients to self-care programs, to guided self-care programs, and to support groups. And certainly in my experience, this has been an enormous help to patients who are battling an illness which we know so little about. Mostly the patients need us to listen, to validate, and to reassure them that we recognize their symptoms, their non-recovery, and that we are looking for solutions for their problem. And I think quite importantly for us as scientists, to link them to research programs so that we can contribute in a meaningful scientific way to their illness. We need to establish primary care services to perform this follow-up, and we need to establish specialized care services for the minority of patients who might be at great risk for new organ dysfunction, new major medical diagnoses, and perhaps even an increased risk of death. But we need to be able to predict who those patients are. We should be able to predict whose help they need the most and where they should be able to access those services. And those are health system planning sort of questions. So in summary, acute COVID-19 casts a long shadow. Long COVID is an inescapable public health priority, and I would say an inescapable scientific priority. The scale of the pandemic will ultimately determine the scale and burden of long COVID. We need a coordinated healthcare response and probably a multidisciplinary approach. I think the medical community is currently grossly underprepared to deal with long COVID. We need to be organizing ourselves in a far more coordinated way and with a much greater appreciation of the need to merge scientific efforts with the clinical coalface. The post-pandemic world simply cannot be characterized by large-scale, persistent impairment and disability. That would be reminiscent of the post-polio world, and it can't happen. Our major priorities are for prevention and effective treatment of acute COVID-19, for greater understanding of the mechanisms underpinning the development of long COVID, for linkage of existing clinical cohorts to research programs, a greater ability to predict long COVID, for the identification of effective interventions for long COVID, and for the development of service models for the care of people with long COVID. So with that, I thank you for the indulgence, and I look forward to the discussion. Thanks very much.
Thank you, Dr.
Thank you so
Perumal.
much. That's a great presentation, Dr. Perumal. Really excellent presentation and very comprehensive analysis. By the way, and you have alluded this at the beginning, this webinar gives me the opportunity, and it's a great pleasure to announce that CAPRISA is now being a member of the Global Virus Network Organization, and it's really a fantastic step, and obviously also with the contribution of Dr. Salim Karim. So we will move to some questions.
So we have one question in the Q&A box. Would you please click and then you see the question?
Yes, it's an anonymous spectator attendee. If vaccine reduce the severity of disease, what is their significance if they do not reduce effect of long COVID regardless of the severity of disease?
So I think thankfully some of the data suggests that not only do vaccines reduce the severity of disease, but they also reduce the likelihood of long COVID in breakthrough infections. And more than that, vaccinating individuals with long COVID, and that might have implications for, say, booster vaccines, seems to ameliorate symptoms in at least half of those individuals. So I think we're starting to accumulate evidence that vaccines, and certainly maybe even boosters, might be an important way of ameliorating the burden of long COVID.
Yeah, that's if I may, this is a key point, and this question is interesting to consider. And also, you have presented some very provocative results, although we do appreciate that these are early days, on the effect of vaccines against the long COVID once it has been established. And it will be very interesting to comment on this. For the second comment, which is on your excellent presentation, yes, we have recording. And if you agree, Dr. Perumal, we will ask you to send us the slides and we will post them, because this is a great presentation.
Sure, no problem at all.
Do we have other questions?
That's it.
I believe that the point that you have made, Dr. Perumal, on the risk with Omicron is also a key question we would like to try to contribute to resolve, I mean, with the Global Virus Network. And you really made the point that because of the huge contagiosity of Omicron, even though the severity, the intrinsic severity is less, at the end of the day, the number of cases might be very large. Do you have information, on the other hand, on the impact of Omicron on the brain tissue or on the vessels? I mean, do we have some more direct evidence for a differential impact of this variant as compared to previous variants?
Yeah, I think that's a really important question, because really at the heart of the question is there something more to the relationship between variants and long COVID than simply their propensity to cause severe disease and their propensity to infect individuals? And that is whether or not variants have a particular propensity to infect certain tissues in the body. Now, some of the data that came from the post-mortem study suggests that there are genetic differences, subtle but detectable genetic differences between the RNA identified in the brain tissue and in the lung tissue. So there is some indication that there are certain genetic changes which must occur as the virus copies itself in the host in order for that RNA to become lodged in certain tissues. Now, whether that is true of more or less true for each variant is yet to be known. And unfortunately, none of the studies which studied long COVID are able to decidedly attribute any of their findings to a particular variant. And I think that as time progresses, those cohorts for which there is available data and where they can go back and genotype and so on, might be able to come back to us with that kind of answer. Certainly, some of the series are long enough that they've covered, say, 2 or 3 waves of infection, and they might be able to offer us the kind of answers we're looking for. But none of the data is being reported in that way yet.
Thank you so much. I believe that we have to stop this session. Dr. Perumal, thank you again. This has been a great presentation, and we really hope to have you working in the context of the Global Virus Network on all these fascinating topics. So thank you. We have maybe another question, sorry.
Yeah, there's another.
Oh, sorry. Is there any resemblance, I guess, of consensus on how physicians should offer treatment for long COVID? What treatments are contraindicated?
Oh, this is a much more difficult question. And I think we're still at the point where we're beginning to understand the biological mechanisms. And I think we're still some way away from therapeutic interventions. Certainly some ideas like microthrombosis or microclotting, that sort of idea is moving into early phase clinical evaluation. And I suspect that we will gain some insights from that kind of early work, but we're still quite far away from seeing therapeutic interventions for any of the other biological mechanisms. There are some interventions which I think are intuitive, which are available, and which come with relatively little harm. And those include the use of antiviral therapy early on in the disease so that we can reduce viremia, which tends to portend a high risk of SARS-CoV-2, vaccination, which we've already talked about, and to some extent, we could look at substantiating, say, the arguments for anticoagulation a little longer than in the acute period. So there are those practices which are an existing practice, which we can extend some evidence for, and there are those for which novel interventions will need to be designed, for which we simply just don't have the data yet. Thanks.
Absolutely. We have another question, Dr. Kayatman. So thank you for this excellent presentation. The fact that we see a reactivation of Epstein-Barr and CMV in patients with long COVID is, to my point of view, an indication of the existence of an immunosuppression. Do we see this reactivation in all patients with long COVID?
Yeah, I didn't talk to this aspect in great detail, but it's incredibly important, and the data is coming in quite fast. You know, about 15% of patients who are hospitalized with acute COVID-19 have detectable viral burden from EBV and CMV. And about a similar proportion of patients with long COVID have detectable viremia from CMV and EBV. Now, that's probably due to impaired interferon signaling. But these two viruses are well described in the chronic fatigue syndrome literature. And they have a propensity to cause these kind of protein manifestations that we can see. And even especially for EBV, the dermatological manifestations and joint manifestations, which we sometimes see with long COVID. And there is now data to suggest that at times when patients have a flaring of their long COVID symptoms, the viral burden of EBV tends to be concordant with those presentations for those patients who have detectable EBV viremia at their time of long COVID diagnosis. So I think there's interest there. Herpes is emerging as another potential virus which reactivates during acute infection. And in one cohort, about 10 to 15% of patients reported shingles at some point in the 12 months following their acute infection with COVID-19. So there is this emerging understanding of secondary viremias from acute COVID-19 and perhaps related to long COVID. And there might be a therapeutic intervention we could apply there too, you see. Thanks.
Thank you. We will close with a final question. This is from the anonymous attendee. I had COVID-19 last month, and a few days ago, I developed sneezing and blocked nose. Could I be having long COVID symptoms?
Yeah, the short answer is yes. But as we know from the WHO definition, we should really try to wait out a 3-month period, that we should allow these symptoms from initial illness, which can remit and recur within the first 3 months, to establish themselves. They should persist for at least 2 months in continuity, and they should be present at 3 months from the initial diagnosis. And if that point is reached, then I think you should be searching for more answers about why that is the case. But until that point, symptomatic measures seem to be sufficient for the vast majority of people who go on to resolve their symptoms before 3 months.
Exactly. Thanks. We could be reassuring. Well, thank you so much again, Dr. Perumal, and we will close now. Great presentation, and we wish everybody a very good day, afternoon, evening. Thank you.
Thanks very much. Goodbye.